Hey, welcome back everyone. We are on the outline blueprint, PTCB blueprint outline 6.0, medication order entry and fill process. Medication order entry and fill process. So the pharmacy order entry and fill process makes up the dispensing process in the pharmacy. This is true whether it is in a retail setting or in a hospital or a skilled nursing pharmacy, inpatient like in a hospital. And it's all the same. You're going to be filling prescriptions, reading medication orders or prescriptions, and then inputting them into a computer system. Pharmacy technicians are permitted to perform a wide variety of tasks, and the tasks during order entry and prescription filling process may include accepting new prescriptions from the patient, such as in a retail setting at the counter, receiving prescription refills from the patient. I mean, the patient will call the pharmacy, I want these refilled. Or you might have a IVR system, interactive voice response. Well, they'll call their prescription into the pharmacy's phone system, which is then integrated with their computer system, and then they punch in their prescription number from their prescription bottle. Requesting refill authorization from the patient's prescriber, collecting patient information, maintaining patient profiles, entering patient, prescriber, and medication information into the pharmacy's information system, which is usually the computer, and interpreting the prescription SIGNA. Remember the SIG, or the directions, right? So let's see, what else? You guys can also do billing prescriptions to third-party prescription providers. Remember, after you send the send button to send the claim to the insurance company, it's called online adjudication. Remember that from the last lecture. Counting and pouring the correct medication, labeling prescription bottles, returning medication bottles to the pharmacy shelves, repackaging medication, and preparing unit dose medication if you're in a skilled nursing pharmacy. I just want to say something quick about returning bottles. So that's the difference between a pharmacy technician and a pharmacy clerk. A pharmacy clerk and a pharmacy technician can return bottles to the shelf where they belong, but only a pharmacy technician may pull bottles from the shelf to fill a prescription. So if an order comes in from McKesson or Cardinal or Bergen, a pharmacy clerk can also put the prescription order up. But when it comes to actually filling and dispensing a prescription, only the pharmacy technician and pharmacist and pharmacy intern can pull the shelf off of the bottle in order to fill the prescription. And of course, you'd be checking the NDC number, right? 6.1, the order entry process. So this is the method of receipt of prescriptions, which include a walk-in patient or customer. They walk into the pharmacy, they come to your window. A call-in. The original prescription of non-scheduled and schedules 3, 4, and 5 controlled substances may be telephoned in by the prescriber or his or her representative, like a nurse or a med tech, whatever, a PA, nurse practitioner. Those can all call in prescriptions. A patient may call on a refill if there's refills left on his or her prescription. A lot of times they may not even know if they have refills. They don't read their bottle properly. And then e-prescribing, right? That's electronic prescribing, and then also fax. So those are different order entry processes. The fax is still, even though as old as the technology is still one of the most common ways that prescriptions come into the pharmacy. Either because they're approving a refill from the doctor's office. So what happens is if the patient requests for a refill and then you as a pharmacy tech notice there's no refills, you're going to fax over a refill request or authorization to the doctor's office, and then a day later or maybe even the same day they fax the authorization back to the pharmacy, and then you'll retrieve it from the fax machine and then put that into the computer system. Okay. And then you're seeing more and more of e-prescribing these days as there's more adoption of electronic prescribing. Let's go to page 2. So the pharmacy dispensing process all starts with order entry, of course, and that starts with intake at the counter. So if it's a new patient, it's going to be a new intake process for that patient. So greeting the patient and taking a medical or prescription history for the patient's initial profile that will be inputted into the computer software system, their current address, their date of birth, their sex. Then you want to obtain the correct doctor information that the patient saw, and you want to obtain the patient's insurance card. Let's let this car truck go by. You want to obtain the patient's insurance card or other carrier information. So everything that you need to do to be able to process the prescription should be on the patient's drug insurance card. Now don't get that mixed up with their medical insurance card. It's a different card than their drug prescription card. Sometimes it's on both. The medical insurance and the drug insurance could be on the same card, but usually they're two separate cards, because their medical insurance card won't have their carrier and group number on it to be able to process the prescription. Most pharmacies will give a patient profile handout for the patient to fill out that includes a drug. They include drug and food allergies, OTC meds, vitamins, and herbal supplements, and disease states and any other pertinent information necessary for safe dispensing of the patient's medication. So they'll usually give them this profile, blank profile, put it in a clipboard, and they'll fill out if they're a new patient at your pharmacy. F, it is the responsibility of the pharmacy technician to make sure all pertinent information is given in order to input a complete profile for the patient in the computer system. And then I, 1F, the patient profile provides the patient's health history and is maintained in the pharmacy's computer system. So in the patient profile, it'll have like any allergies they have. So if they have a drug allergy, let's say to penicillin, and the doctor prescribes for penicillin, it should catch it. There'll be a drug utilization review. There'll be a hard halt asking the pharmacist to intervene, saying this patient's allergic to penicillin. Why is he getting amoxicillin? Okay, 2. If the patient is new, input all information from the patient profile that was filled out by the new patient into the computer system, including insurance carrier information. We just talked about that. 3, read the prescription order, in other words, read the prescription, and transcribe the prescription information into the computer system, so data entry, right? And so these will include the drug name and strength, the drug directions or SIG, the quantity, and any refills if pertinent. And remember, Schedule 2 drugs are non-refillable. Schedule 3, 4, and 5 controlled drugs are refillable up to 5 times in 6 months, whichever comes first. And then the doctor name, and make sure all the doctor's information is there, including, let's go to page 3, including the doctor's DEA number for insurance billing and their state license. And their state license is required for some states because they may be on Medicaid, or in California it's Medi-Cal, the welfare recipients. So that's how those Medicaid insurance companies usually bill. But not all states do this, so it just depends. So you want to get their DEA number, state number, and then also every physician has an NPI number. So the DEA number, their state license number, and their NPI number is unique to the prescriber, to the doctor, or to the nurse practitioner NPA. Now the NPI is Dr. NPI is the National Provider Identifier number. So type that in or write it in. National Provider Identifier number for billing purposes. And it is a 10-digit identification number issued to healthcare providers in the U.S. By the Centers for Medicare and Medicaid Services, or CMS. This is a federal organization. Okay, 6.2, intake, interpretation, and data entry. Intake is the same as 6.1 above. Intake includes greeting the patient, smile, obtain pertinent patient information for the electronic profile in the computer, and pertinent and current drug insurance information along with the insurance card, because remember you got to get the BIN number and the carrier and group number if the insurance uses that. 2, intake also involved in the identifier like a birthday or address. 3, any pertinent release and waiver forms will be signed at this point. An example is like for a non-child resistant cap. So the default is that all patients get a safety cap, a locking safety cap. But if they're older, maybe they have arthritis, they don't want the safety cap, then they will sign the waiver saying they want a non-safety cap or non-child resistant cap. For intake is also where sometimes a pharmacist intervention in the form of patient drug history and consultation is required. The pharmacy technician must get the pharmacist involved because you can't do this, right, as a technician, wherever consultation is warranted. Remember, a pharmacy technician can never give drug consultation of any type. I don't know how many times I've said this, but I know this exam tries to trick you, asking or trying to get you to answer a question that says that you can consult in certain situations. You can't consult in any situations, 0 situations, okay? So don't get fooled by those questions. B, interpretation. Correct interpretation when reading a prescription is paramount to patient safety and reducing dispensing errors in the pharmacy. A, identify the name, strength, dosage form, and quantity of medication to be dispensed, and identify the route of administration, and identify the frequency of administration, and to determine if a generic drug may be dispensed. If there's a DAW on it, dispense as written or do not substitute, then you can't substitute for the generic if there is a generic. Let's go to page 4 at the top. E, identify the number of refills permitted by the prescriber. If no refills are indicated by the prescriber, then 0 refills will be permitted. Sometimes a doctor on a non-controlled substance will put PRN as the refills. If it is PRN, then that means that you can refill it up to 1 year. F, when in doubt about interpreting the prescription, always ask the pharmacist for clarification. And if the pharmacist has questions regarding your prescription, then they'll contact the prescriber. 2, be aware of look-alike, sound-alike drugs during interpretation of the prescription order. Again, an earlier one was hydralazine and hydroxyzine. Those look alike and sound alike. 3, if unsure, always seek the advice of the pharmacist on shift because guessing could lead to grave consequences, and including something that could be potentially fatal. 4, pharmacy language. Medical abbreviations. You want to look at the PDF resources on the website. Medical abbreviations, the PDF, the medical abbreviations PDF. Know these terms. Know them all. Take them with you. Study them. The pharmacy technicians may encounter medical abbreviations on patient prescriptions, in patient charts, and in various types of drug literature. Therefore, pharmacy technicians must have the knowledge to interpret these abbreviations correctly so that errors do not occur. Most of the abbreviations in the medical world in the United States are standardized, so you shouldn't have to guess what the abbreviations are. B, pharmacy abbreviations. So we have medical abbreviations, now we're talking about pharmacy abbreviations specific to the practice of pharmacy. Go ahead and print that resource document. It's called the Pharmacy Abbreviations PDF. And know these terms. Know these terms along with common SIG codes, common direction SIG codes. The Common SIG Codes PDF. There's a PDF for Common SIG Codes. The pharmacy abbreviations are found in prescriptions, medication orders, and patient charts. And many of the abbreviations are derived from Latin and are used to identify weights, volumes, dosage forms, and routes of administration, frequency of taking the prescription, such as BID is twice a day, TID is 3 times a day, QID is 4 times a day. And directions in compounding, and then the names of medications. C, medical terminology. Again, go ahead and print this resource out, a PDF resource called Medical Terminology. So medical terminology consists of, we went through this in a PowerPoint lecture, the root words, the prefixes, and the suffixes. And by combining various root words, prefixes, and suffixes, then a medical word is formed, right? You can pretty much define what it is if you know all your root words, prefixes, and suffixes. Okay, C, data entry. Again, let's see 6.1 above. Let's go to page 5. So 2, accuracy in data entry is really, really important. Just the interpretation of the order is not enough to ensure patient safety. Always double check any data entry inputted into the pharmacist's computer system, and look for inaccuracies and mistakes. So a little insurance up front can go a long way to correcting a mistake or misfill in the future. So again, 2, minimize distraction. Remember, don't do this. An unnecessary conversation when engaged in the dispensing process. And this is particularly true during the data entry stage. 3. Entering the information into the computer system. A. The information required is prompted. B. Quantities are expressed in metric units. Remember I talked about that earlier? So if something comes in an ounce, like 1 ounce, it's not, you don't put 1 ounce into the computer system, you put 30 grams. If it's 2 ounces of a liquid, you don't put 2 ounces, you put 60 milliliters. And if it's tablets or capsules, they'll just be each quantities, 10 capsules, 30 capsules, 100 tablets, whatever. 9. Input the correct dispenser's written code. Remember, the DAW1 would indicate that the prescriber or physician or dentist or veterinarian, they want the brand name drug dispensed if it comes in generic. That's a DAW1. DAW2 is the patient. Remember that. DAW1 is the prescriber and DAW2 is the patient. The patient says they only want the brand name. D. Calculate the day's supply of the medication, and this is usually dictated by the insurance plan limitations, like a 30-day supply. They'll only cover for 30 days. So if you try and bill for 60 days, it's going to get rejected. E. Third-party adjudication. Remember, adjudication is online billing. It's submitting the prescription for payment by third-party drug insurance provider. So if the prescription drug insurance company denies the payment, the patient is responsible for full payment of the prescription unless the rejected claim is corrected and resubmitted to the third-party prescriber prescription drug provider. If a prior authorization is necessary and appropriate, then this would be the time to execute a prior authorization with the insurance company. And you will need the doctor's partnership in getting the prior authorization, because they have to give you the indication and what are the drugs that they've tried that have failed, etc., etc. F. Drug utilization review. Again, this would be prompted by your computer system. This is the process of verifying that the prescription being processed does not interact adversely with another medication in the patient's profile. So that's why it's really accurate or important to get the accurate drug information in the patient's profile, like any allergies they have or any food allergies or herbal allergies. If a warning is observed, the pharmacist is to be notified immediately to determine the proper course of action in filling the prescription, such as contacting the physician or to continue filling the prescription. The pharmacist makes a decision then based on the information on hand. And remember, again, as in the previous lecture, as a pharmacy tech, you cannot override the DOR. Only a pharmacist can override the drug utilization review on the computer system. Okay, page number 6 on the top. 6.3, calculate the dose required. A, pharmaceutical calculations. So a complete study in pharmaceutical calculations will be given in the course. This is pharmaceutical math or pharmacy math. 1, accurate calculations involving pharmaceutical math is extremely important in making sure that the patient is receiving the correct dose or amount required to finish the regimen. A, often dosing is calculated in an inpatient pharmacy setting and then verified by the pharmacist. Like if you're going to be reconstituting something or making a TPN, for instance, Hyperal TPN, there's a lot of calculations involved, so the pharmacist will usually want to make sure that they verify all your calculations. The technician will do the initial dosing, and then the pharmacist will come behind and then check. B, in the retail setting, though, a pharmacy technician rarely has to calculate dosing for the patient. C, a pharmacy technician must calculate the total amount required to finish the drug regimen. So if the doctor didn't put the quantity, if it said, amoxicillin 250 milligrams, 1 TID for 10 days, but they didn't put 30, well, you know it's going to be 30 because it's 1 3 times a day for 10 days, and 3 times 10 equals 30. So this is often seen with antibiotics and steroids such as prednisone therapy, because there's a tapering dose for prednisone. There's questions on the exam regarding prednisone tapering doses. You'll see examples in the math section too. 6.4, the fill process. For example, selecting the appropriate product, apply special handling requirements, measure and prepare product for final check. A, the fill process is part of the dispensing process, and it encompasses 1, intake of the prescription, 2, order entry, where you verify information has been entered properly, 3, pulling appropriate drug from the shelf. And remember, only the technician and pharmacist and pharmacy intern can pull the drugs from the shelf when they're filling. The pharmacy clerk may not do so. And then you guys will verify the label on the prescription label against the NDC on the bottle, right? The National Drug Code. Then scan the bottle's UPC if your pharmacy has a scanner to ensure the correct medication was pulled. Okay, page 7 at the top. D, count, report, and measure, or use aseptic technique for IV administration. If counting manually, count by 5s, and then always recount. Type that in or write it in. Always recount to ensure accuracy. If any penicillin or sulfa drug is dispensed in the pill counting tray, should be wiped down using isopropyl alcohol, because there are some patients who are severely allergic to penicillin or sulfa drugs. In some pharmacies, they actually have a separate counting sanitary tray just for penicillin and one for sulfa drugs. When dispensing oral chemotherapeutic or hazardous agents, the pharmacy technician should wear gloves to prevent the skin from coming in contact with the medication. And then the counting tray again should be wiped down with isopropyl alcohol. And you want to use personal protective equipment wherever appropriate. 5, select an appropriately sized container and put the medication into the container. Most containers or vials are measured in drams, 13 drams, 16 dram, 20 dram. And then bottles for liquids are measured in ounces. They come in 2 ounce, 4 ounce, 6 ounce, 8 ounce, 12 ounce, 16 ounce, and 32 ounce. 6, place an appropriately sized child-resistant top on the container. That's the default, remember. You only put a snap cap if they signed a waiver when they came into your pharmacy for the first time. If a patient requires the easy open or non-safety cap, then have the patient sign the waiver to that effect. And then that has to be, you have to file that. 7, labeling and auxiliary labels is done next. If there's any kind of auxiliary labels, you want to put that on the side of the bottle next to the label. And then prepare the product for final check by the pharmacist. So the bulk bottle, in other words, where the medication came out of, from which the medication was taken from, should be placed next to the properly labeled and filled prescription bottle so that the pharmacist can properly verify the technician's fill. The pharmacist then checks the completed prescription, and the technician or pharmacist will then bag the prescription and then place it on the shelf. They'll store the prescription bag alphabetically by last name so that when the patient comes in, you can find the bag easily. But let's say that this is the prescription bottle, and let's say that this is the bulk bottle that you got the medication out of to fill the prescription. So let's say the prescription vial has a label on it, and what you want to do is just put the bulk bottle next to the prescription bottle so that when the pharmacist comes, they can check the NDC of the bottle and against the prescription, and then make sure that what came out of the bulk bottle is actually in the prescription vial. Number 10, patient consultation. So ask the patient or person picking up the prescription if he or she has any questions for the pharmacist. It could be a caregiver picking up the prescription for the patient. If yes, then inform the pharmacist who will consult the patient or the caregiver. And in most states, counseling is a requirement for all new prescriptions, and it is a requirement federally for any Medicare patient because of over 90. If the patient doesn't want consultation, then they must sign a waiver to that effect. B, remember, pharmacy technicians are not permitted to counsel. Page 8 at the top. So B, select the appropriate drug. 1, always double check the blank, write it in or type it in, NDC number. Always double check the NDC number when pulling the drug. 2, always double check the prescription with the pulled drug from the shelf. 3, special handling of drugs. 1, so these products should be dispensed in their original containers or packaging to avoid product breakdown and loss of potency. So examples include Pradaxa and nitroglycerin sublingual tablets. They usually come in their own little glass amber bottle to protect it from sunlight. These should be dispensed in the original bottles. Pradaxa doesn't always come in a bottle. It can also come in these blister packs that are foiled. They're in a foil pack. And the reason again is we want to protect the potency and integrity. We don't want to pull those tablets out and stick it in another bottle. Some drugs are compromised by external factors that include moisture, light, or photosensitivity, like nitroglycerin tablets, and physical agitation. So we are aware that many consumers use pill boxes or pill organizers to aid them in remembering to take their medications. However, because of the potential for product breakdown and loss of potency, consumers should not store certain drugs in any container other than the original manufacturing packaging. And so this is the job of the pharmacist. D, measure. So 1, measuring includes reconstituting powdered antibiotics for dispensing with the proper volume of distilled or sterile water. And these are usually always with antibiotic suspensions. When you go into a pharmacy, all the antibiotic suspensions are in plastic bottles, and some of them are in glass, and it has a lyophilized powder on the bottom, and it's ready to be reconstituted by adding water to it. So the antibiotic bottle always prints the proper amount of water to be added or to reconstitute it with to the bottle to make the suspension. So always on the side of the bottle, let's say this is an antibiotic bottle, if you look on the side it tells you to be reconstituted with 88 milliliters of water. It tells you exactly, so you don't have to guess. And then you would just go and get a graduated cylinder and pour like if it's 88 milliliters of water, you would put in, measure out 88 milliliters. And then sometimes in some pharmacies they have a reconstitute that hangs from, over the sink. And it's like a graduated cylinder, and it has, you open this stopcock valve and the water comes through from a big distilled water gallon up above, or sterile water. And it goes into this plastic reconstitute. Then you stop it when you have the desired amount of water that you need to reconstitute the antibiotic, and then it goes into the antibiotic suspension bottle. Measuring also includes the proper volume of solution used when employing aseptic technique for IV admixtures. And so these may include making dosing syringes for the patient. E, final check. Review above, and remember, type this in or write it in. Only the pharmacist does this. Only the pharmacist does this. Only the pharmacist does the final check. Page 9, 1 above. 1. The final check is always done by the pharmacist. 2 terms you should know are PV1 and PV2, since some pharmacies employ these terms. PV1 is pharmacy verification, is when a pharmacist checks the original prescription visually when the technician types the prescription into the computer. PV2 is when the pharmacist actually does the final check. So that's the difference between PV1 and PV2. This would be the finished product that would be dispensed to the patient. It includes labeling and any auxiliary and special handling labels, like shake well, or keep out of sunlight, refrigerate. Okay, 10.5, labeling requirements. So auxiliary and warning labels, expiration date, patient-specific information. So A, labeling requirements refer to proper labeling on a prescription, and these include 1, bottles, topical products such as a tube or a patch, liquid, powder, otic and ophthalmic preparations, and reconstituted antibiotics. 2, IV admixtures, syringes, and any pharmaceutical product prepared in a laminar airflow hood. And then 3, insulin such as bottles and pens. We got this lunchtime siren going on in the background. Sorry about that. Let's wait until it's over here. Okay, B, general requirements for prescription drug labeling. So please keep in mind that your state board of pharmacy may have additional labeling requirements. So it could be governed, so it's governed by your corresponding state board pharmacy. And these can include the name and address of the pharmacy, the serial number of the prescription, otherwise known as the prescription number, the state of the date of the prescription. This is the date of filling or refilling. The name of the prescriber, the name of the patient, the directions for use, such as a SIG, including precautions if indicated, and the name of the drug and strength, if any. Let's go to page 10. And also 8, any cautionary statements. C, not required on the prescription label, but very common, are the address of the patient. Most pharmacies don't put the address of the patient on there. The initials or name of the pharmacist, the telephone number of the pharmacy, the manufacturer's lot number. It's required for long-term care facilities like skilled nursing homes. So when they get their blister pack on the card with the medication, the lot number has to be on there. The name of the manufacturer, distributor, the quantity of the medication dispensed, and the number of refills left. D, sterile product prescription labeling. This is for aseptic products, CSPs, right? Compounded sterile products. 1, the pharmacy name. 2, the patient name. 3, the date of filling. 4, the ingredients, like the strength and quantity of each drug. 4, total volume. 5, directions for use. 6 directions for use. 7, infusion rate. And then 8, the beyond use date, BUD. In other words, you can't use it past the beyond use date. E, repackaged medications. And so these are usually done in skilled nursing facilities, skilled nursing pharmacies. SNF. We call it SNF for short, skilled nursing facilities. So these are usually like long-term care homes, right? Only enough medication as needed for a limited time period should be repackaged, and the following information is required on a repackaged medication. 1, the name of the medication. 2, drug manufacturer's name. 3, the dosage form. Let's go to page 11. 4, the strength of the drug. 5, beyond use dating. Often it's 1 year, whichever comes first. 6, the lot number or batch number of the medication. So again, those are for repackaging. F, unit dose labeling. So these are again usually used for skilled nursing facilities where a skilled nursing pharmacy will repackage the drugs and put them into little blister packs. You saw a picture of a unit dose packing card, blister pack card in the PowerPoint lectures. 1, the trade or generic name of the drug. 2, the drug manufacturer. 3, the strength of the drug. 4, the beyond use dating or BUD. 5, the lot number of medication. And then 6, a unit dose log must be maintained. G, the repackaging log. So the repackaging log contains documentation required for repackaging medication and must be signed by the pharmacist. Again, repackaging is what you normally see in a skilled nursing pharmacy that just specializes in skilled nursing facilities. 1, the date of repackaging. 2, the name of the drug. 3, the drug strength. 4, the dosage form. 5, drug manufacturer. 6, the lot or batch number. 7, the drug manufacturer's expiration date. 8, the BUD assigned by the pharmacy, and again, after 1 year or less, whichever comes first. 9, the quantity repackaged. 10, the pharmacy technician initials if repackaged by a pharmacy tech. 11, the pharmacist initials. And then 12, the repackaging log must be maintained and always updated. So this is these repackaging logs are usually, again, you saw this in the PowerPoint lectures. It's usually just a card, and it has all this information. It has columns, and so it has the date of repackaging, the name of the drug strength, the dosage form, the lot numbers, all that, the initials for the pharmacist, initials for the tech. So it's just usually on a little card, and each card is specific for each drug that is repackaged. So each card will have the NDC number of the drug that's being repackaged. And again, you never see this in a retail pharmacy. This would be either in a hospital setting or for a skilled nursing pharmacy. So let's see, page 12 at the top. H, labeling of OTC or over-the-counter or non-prescription drugs. So sometimes we do dispense OTC drugs. The OTC drug labeling are usually associated with the manufacturer as per FDA regulations. However, once the drug is removed from its original container, original package, and sold to the patient, then it must meet the general requirements of prescription drug labeling. So there's no exception here just because you pulled out some OTC drugs out of a bottle and stuck it in a prescription label, and then you can't just give it to the patient with no label or anything. You have to abide by the prescription labeling laws at that point. And so this is especially true for long-term and skilled nursing facilities. If you're going to dispense an over-the-counter drug in a skilled nursing facility in a blister card, blister pack, you have to have all the labeling requirements as if you have to treat it like it's a prescription or legend drug. Auxiliary and warning labels. 1. Auxiliary and warning labels are additional labels placed on a prescription bottle that is in addition to the main prescription label as described above. And there are several auxiliary or ancillary, sometimes they call it ancillary, labels that can be placed on a bottle. And they can be purchased separately by the pharmacy, or in most pharmacies these days, they're printed along with the main label on the pharmacy computer system by the pharmacy software system. And some examples include, and you've seen pictures of this in the PowerPoint lectures, may cause drowsiness, do not drink alcohol, do not take aspirin or aspirin-containing products, may cause discoloration of the urine or feces, avoid prolonged or excessive exposure to direct sunlight, medication should be taken with plenty of water, shake well, there's dozens of them. J, the expiration date. So the expiration date, I don't know why I can't pronounce that today, but the expiration date should always be on the prescription label. That's the expiration date of the drug that comes from the bottle. A pharmacy may use an expiration date of 1 year as a default if the manufacturer's packaging expiration is greater than 1 year from the date of fill. Now, why is this? It's because they want to make it easier for pharmacies to fill prescriptions. So you can set the computer system to a default of 1 year because you're assuming that most of the bottles that you're pulling the drugs from have an expiration date that's more than 1 year. But for any reason, if the bottle that you have is less than 1 year, if it's going to expire 6 months from now, then you have to go and adjust the prescription label to reflect that expiration date that is less than 1 year. Okay, page 13, the top. K, patient-specific information. So this is any kind of pertinent information in addition to what is required on the prescription label. And this is not very common in real practice. Okay, 10.6, packaging requirements. For instance, types of bags, syringes, glass, PVC or polyvinyl chloride, child resistant or light resistant. A, manufacturers of prescription drugs may package such drugs for distribution to pharmacies in different types of packages depending on whether the manufacturer intends that the package will be the one in which the drug is ultimately given to the patient, or whether it is intended that the pharmacist will repackage the drug before it is dispensed to the patient. So an example of this would be like birth control pills or inhalers or the Medrol dose pack. Those you dispense the way it comes from the manufacturer. You're not going to pop out all the little birth control pills out of the foil wrapping and put them in a bottle, right? You're just going to dispense it that way. It was meant to be dispensed as a unit of use by the manufacturer. B, types of containers, types of container uses. So we have round vials, and so these are used for solid dosage forms such as capsules, tablets, and etc. And remember, and they're usually amber colored because they have to be light resistant. You don't see clear round vials these days. The other thing, again, like I said earlier, is that round vials, prescription bottles, are always come in drams. So when you order from the wholesaler, it comes in 8 dram, 12 dram, 16 dram, 20 dram, 40 dram, 60 dram. 2, prescription bottles. So these are used for liquids, and they're always amber colored also. So they're used for liquids of low viscosity, and they don't come in drams. Although a dram could be a liquid measure, they come in ounces. So it comes in 1 ounce bottles, 2 ounce, 3 ounce, 4 ounce, 6 ounce, 8 ounce, 12 ounce, 16 and 32 ounce bottles. 3, the wide mouth bottles. These are used for bulk powders or large quantities of tablets. If you're dispensing like 400 tablets or capsules, then you would use these wide mouth bottles. So they can be used for tablets, capsules, and viscous liquids that cannot be poured readily from a narrow neck container. Viscous means the viscosity or how thick it is. The more viscous it is, the more thick it is, right? 4, dropper bottles. So these are used for ophthalmic, for nasal, for otic, or oral liquids to be administered by a drop. So there are some medications where you want to drop it under the tongue in sublingual use, for instance. 5, applicator bottles. So applicator bottles are used for applying liquid medications to a wound or skin surface. And then ointment jars and collapsible tubes. And so these are used to dispense semi-solid dosage forms like ointments and creams. And ointment jars usually come in ounces too. They come in 1 ounce, 2 ounce, 4 ounce, etc. 6, hinge lid or slide boxes, and these are used for dispensing suppositories and powders. Okay, page 14 on the top. The types of bags. And we're talking about aseptic technique here. So 1, IV admixture bags come in different sizes depending on the volume needed to be delivered. A, small volume parenterals, or IVPV, IV piggyback, are usually 50 or 100 milliliter bags. I've said all this before, so this is just kind of a review. So these are usually used to deliver drugs using the IVPB as a delivery vehicle. And usually the IV piggyback is only delivering one drug, one active ingredient. And so it could be just like an antibiotic that is going to be run into the main line from the large volume bag. Examples include antibiotics or anti-nauseants like Reglan or metoclopramide. Large volume parenterals are usually larger. They're 250, 500, 1,000, or 2,000 milliliters, with 250 and 1,000 milliliter bags being the most common. They are used to deliver large volumes of liquid to the patient, and of course they have to be sterile. C, IV admixture bags include normal saline. We've already talked about this. Remember, normal saline is 0.9%, which means by definition of percent, 0.9 grams of sodium chloride per 100 mils. Half normal saline, which would be half of 0.9 or 0.45%. Quarter normal saline, which is 0.225% or 0.25 times 0.9%. D5W means dextrose 5% in water, or 5 grams of dextrose in 100 mils of water. D10W is 10% dextrose in water. Lactated ringers, and then mixtures. There's mixtures like a D5W and normal saline, or D10W and half normal saline. So bags are usually polyvinyl chloride, PVC, but sometimes certain drugs can react with PVC. They usually react with the sides of the bag, and therefore a non-PVC bag must be used in those situations. D, syringes. Sometimes syringes are used as a delivery device for oral and rectal use. E, glass. Glass will be used in certain situations whereby the drug may react with the plastic container. So sometimes there are some chemotherapeutic drugs that you have to dispense in glass. Other than that, you rarely use glass unless it's in a special circumstance situation. F, child resistant. So the blank, write this in or type it in, Poison Prevention Packaging Act of 1970. The Poison Prevention Packaging Act of 1970. I'll give you a little bit of time to type that in. Poison Prevention Packaging Act of 1970. It required the use of child-resistant containers to prevent injury and death to children age 5 and under. This was actually a result of the Tylenol poisoning. that occurred where someone put cyanide poisoning in Tylenol products over the counter. Okay, so the Poison Prevention Packaging Act 1970 required the use of child-resistant containers to prevent injury and death to children aged 5 and under. In other words, we don't want children 5 and under to be opening prescription bottles or over-the-counter bottles. 2, the default is to dispense prescriptions in child-resistant containers. So when a patient comes in for the first time, we automatically will dispense a child-resistant container unless they sign a waiver for a non-safety cap or non-child-resistant container. So if the patient does not want the child-resistant container, they must sign a waiver. 3, exceptions. There are some exceptions from the Poison Prevention Packaging Act, which include, page 15 above, powdered unflavored aspirin, such as BC powders. They still make it, actually. Remember, you don't give aspirin to children because of Ray's syndrome. B, nitroglycerin or nitroglycerin sublingual tablets. Oral contraceptives, they're already in their little pre-packed foil wraps. Oral inhalers, hormone replacement therapy, and powdered iron preparations. D, light resistant. So the reason there are light resistant containers for drugs is that some medications are severely negatively affected by light. They're photosensitive. Prescription bottles that are usually colored to prevent light from degrading the medicines. Otherwise, direct light can damage the medicines by photochemical reactions. So most of your bottles are amber, although I have seen blue bottles too, which is harder, more rare to see blue bottles, but I have seen some pharmacies have blue bottles. They tend to be more expensive than amber, so pharmacies usually just order the amber color. 2, prescription bottles are typically orange, or amber, which is an extension of the amber color. So it is effective and has low production costs, and the orange color helps to prevent light from penetrating through the prescription bottles and degrading the medicine. Tetracycline is highly sensitive to photosensitivity or photolight, and so it can be degraded quickly. Orange color has been adopted by all major prescription bottle manufacturers, and it is rare to see any other color than orange in the United States. Again, I've seen some blue. 10.7, the dispensing process. So, validation, such as validation, documentation, and distribution. A, the dispensing process is the last step before the prescription is given to the patient. Often the filling process and dispensing process are used interchangeably. Dispensing includes all of the steps necessary to translate a prescription order or prescription into an individualized medication supply that is both safe and appropriate. B, validation. So often the term PV2, right, pharmacy verification, is used for validation of the prescriptions, the final check, before it is given to the patient. Page 16 at the top, the last page. 2, the pharmacist will verify the final prescription order, which includes the correct drug and NDC number. Remember, they have the prescription bottle and then the bulk bottle. They'll check the NDC number. The directions are safe. Any potential drug-drug or drug-food interactions, the correct patient, the quantity sufficient to finish the drug regimen, especially if it's an antibiotic, for 7 days, for 10 days, you want to make sure there's enough in there to finish the regimen. And any other pertinent information regarding the drug and the patient. C, documentation. So the pharmacist will initiate both the prescription document and the prescription label. And so this includes IV admixtures in a hospital pharmacy. 2, if the prescription was covered by a patient's insurance or third-party carrier or insurance company, then the pharmacy must obtain the patient's signature for the prescription being picked up. So when they come to the counter, they're going to pay for their prescription. It's in a bag, and it was covered by insurance. They have to sign this log, so that if the insurance company comes in to audit the pharmacy, they want to see that patient actually picked up that drug that they actually paid for. And if they don't see a signature that it was signed by the patient who picked up the medication that was covered by the insurance company, they can reverse the payment. They'll reverse the payment, and they may even fine you, but they can reverse that payment. So you always want to make sure that you capture all signatures for patients that come in to pick up their medication that was covered by their insurance company. Today, it's usually done by electronic capture. It's the same one that they sign if they're going to sign for a debit or a credit card. They sign on the same electronic capture pad. Of course, they don't have to sign if they pay cash, right? So this procedure is to avoid fraud, and this is usually done when the prescription is sold. 3, any waivers are also signed at the counter. And this could include the waiver to not receive drug counseling by the pharmacist if it's a new prescription, right? Because you're required to, the pharmacist is required to consult for a new prescription. Oh, I gotta take a breath here. 4, numbers 2 and 3 above do not pertain to a hospital inpatient setting for obvious reasons, right? Patients in a bed somewhere, in a room somewhere in the hospital or in a skilled nursing facility. D, distribution. So distribution just means how the drug is delivered to the patient after the dispensing process. So this could include at the retail pharmacy counter, mail order, hospital inpatient setting, skilled nursing facilities, and then most recently door-to-door delivery with internet pharmacies. Someday you're going to see Amazon get into the pharmacy business. And they are going to change the whole industry, just like Uber and Lyft has done with the taxi industry and Airbnb has done with the hotel industry. Okay, that's the end of the lecture for 5.0 and 6.0, medication order entry and fill process, and we will see you in the blueprint outline 7.0 next. Good job, everyone.